Welcome, everyone, to the International Childbirth Initiative webinar series on the 12 steps to safe and respectful mother, baby, family, maternity care. My name is Michelle Scartharian, and I'm the Executive Director of the International Childbirth Initiative. ICI is a framework for implementation and quality improvement that strives to achieve the 12 steps for safe and respectful mother, baby, family, maternity care through a self-evaluation and reflective process that is conducted at the facility level. ICI is also a global resource network of facilities striving to share their learning and improve the provision of care. It was created through the joint effort of the International Federation of Gynecology and Obstetrics and the International Mother-Baby Childbirth Organization. We include over 30 partner organizations and continue to grow, and ICI is open to all birthing facilities who are willing to commit to delivering safe and respectful mother, baby, family, maternity care. Today's presentation will be delivered by Caroline Homer, who is a midwifery researcher with the Burnet Institute in Australia. She leads research and development projects in Australia and internationally, with a focus on health services delivery, reproductive, maternal, and newborn care, human resources, and midwifery education. Caroline has been involved in midwifery continuity of care for the past 20 years. Presenting with her today is Deborah Pascali-Bonero. Debra is a doula and doula educator, as well as the co-chair of the International Childbirth Initiative and the chair of the International Mother-Baby Childbirth Organization. After Debra will be Nese Karabekir. She is a birth psychotherapist, a co-founder of the Istanbul Birth Academy Birth with No Regret program. She is also the president of Hand to Hand for Births Association and the vice president of ISPPM, the International Society of Perinatal Psychology and Medicine. Today's step is step 11, provide a continuum of collaborative care with all relevant healthcare providers, institutions, and organizations. And with that, I'm very pleased to pass you to Professor Caroline Homer.
Thank you so much, Michelle. It's a real privilege to be here to speak today on this such important work that ICI has been leading globally. And it's a real privilege to be giving this talk with Debra and Nese as well. And I'm really looking forward to the session, and I hope you are too. So step 11 is really important because it is about bringing everybody together. It is about providing this continuum of collaborative care, maternal and newborn care, and bringing together all the relevant health providers, the institutions, the organizations, and of course, the women. It's also about the community and about bringing together traditional birth attendants and others who are attending births, who have been recognized or integrated into the health system. And of course, this varies by country. And so all of your countries will probably have a different list of people and providers at this level. And but it's all about providing collaborative care across the continuum. So by now, I'm sure you're very familiar with the really beautiful work that ICI has been doing now for some years and how important the 12 steps are. ICI works hard to reinforce the 2018 WHO intrapartum model of care that you can see here. And the steps, the 12 steps, and many of them are here, you can see how they fit in with the really important work that WHO has identified as being critical for women to have a safe, satisfying childbearing experience. So issues of respectful care, emotional support, continuity, effective communication, and then the more kind of pointy end things around pain relief, monitoring, fluid and food, mobility, and obviously having a pre-established referral plan. So these are really important critical elements of intrapartum care, and the ICI model fits really nicely into most of these aspects, and so that reinforcement and alignment is very clear in this work. All the steps are interrelated. So today we're going to talk about step 11, but of course you can't have collaboration with having everything else. So step 11 is related to all the other steps, but especially there are two steps that we would like to draw your attention to. One is step 3, which is to provide the mother-baby family maternity care. So this model of care that brings everybody together and keeps the mother, the baby, the family absolutely at the center of care, with the collaborative providers around. And step 4, which is about continuous support. And I'm going to talk a bit more about that as we go through. But continuous support, continuity, collaboration, those C's all line up. They're all part of the same aspect to ensure that women and families get the best care and the most respectful care. So if we look at specifically what step 11 says, so it talks about collaboration, and this is across disciplinary, education, cultural and institutional boundaries to provide the mother baby with the best possible care within this functioning team. And a critical part is that we recognise within the professionals our different competencies, our different skills, our strengths, and how we work together. So that's important so that we don't duplicate and that we work together and strengthen each other's capabilities and capacities. The second important part is around continuity of care. And in this step, we talk about continuity of care from a small number of caregivers. And I'm going to talk a little bit later on about the different levels of continuity of care. These referral links, these networks of care, the link between primary care, community care, and then further into secondary and tertiary care is really important part of step 11. And this is important to build the relationships with the community, of course, but also then to be able to transfer women as needed, or their babies. So particularly for sick women and small and sick newborns. So that really smooth referral pathway for women is absolutely critical. And then finally, ensuring that women have all the available support networks in the community that they need. The facilities, the health professionals, we feel a tiny part of women's lives, obviously a critical part of women's lives, but women go back out into the community, back into their worlds, and it's really important that they're well networked into the community and ensure that they have a network, a support network. And I think that's even more critical now in the post-COVID era. So what is collaboration? This is a word we use a lot. We probably don't think that hard about what collaboration means. And here's a lot of words that describe what is collaboration. In maternity care, in maternal and newborn health care, it absolutely must be focused on the woman, the baby, and the family. So keeping that little unit absolutely at the centre. Collaboration means quality care. It means using the best evidence, the best guidelines, ensuring that the staff are competent, are working to within their scope of practice, that they're committed to the work, they trust and respect one another. That's a really important part of collaboration across disciplines, that they have shared goals, vision, values, and that there's open, honest, and continuous communication. So really important in terms of teamwork. We also need to ensure that the team are responsible and accountable, that they work within these common protocols, within their scope of practice, as I've said already, and this mutually supportive environment. So that we work together and we look after each other and we support each other in the good times and in the bad times. And we'll discuss difficult issues like finances, like ethics, like our professional challenges. Really important that care is, as much as possible, is locally based. So yes, we might need to refer women and families up the line to another town, to another village, to another community, if the care that they need is not here. But the primary care should always be locally based. And then we can use the broader aspect of services. And so we as providers need to know what's in our community, what's available to women, how can they access those services, what are they going to need? So collaboration, simple word, lots of concepts. So does it work? And fortunately, some people have done systematic reviews, and here's one from colleague Schott et al. from 2020, did a systematic review on the contribution of interprofessional collaboration to healthcare, and really showed that this makes a difference, that collaboration brings people together, it bridges those gaps. And I know Deborah's going to talk a little bit later on about the really critical role of doulas bridging that gap between the community and the facility. Collaboration works when professionals can negotiate those overlaps. There's always a little bit of overlap, but we don't want duplicated care. So overlap that we negotiate and we understand is really important. And we create spaces for each of the professions to work to their best ability to work within their scope of practice. And understanding that we all make different contributions. So I'm a midwife, what I bring to the table is very different to what an obstetrician brings to the table, what a doula brings to the table, what a mental health worker brings to the table. They're all important and we all need to work together. And we might work a little bit differently according to the setting we work in. And that depends on whether we're in a community level, a primary, secondary, tertiary level service. So collaboration has got good evidence to say it works. So it's a team. We need to work together across the disciplinary, educational, cultural and institutional boundaries to provide the mother baby with the best possible care. And we recognise each other's competencies and respect each other's knowledge and experience. And that mutual trust, that mutual understanding, learning together often helps bridge these gaps and ensure that these things are possible. So I'm going to talk a little bit about continuity and collaboration. And for me, they're interlinked. So we want collaboration between health providers and with women. We want continuous care. We know that makes a difference. Continuity of care, continuity of carer. And then one of the focus areas we're going to talk about today is continuity of midwife carer. So it's sort of, I guess, a spectrum, and that all aspects are important though, and that our services can deliver possibly some of these all of the time at various stages. And so it's just thinking through what your service can provide at this moment, and then what you might be able to aspire to for the future. I said earlier, there's some different dimensions of continuity. So the sort of top, first level is management continuity. And the way I think about this is that people work within a service that has common values, that has common boundaries that we all understand, and that communicates between one another those issues. So it's a sort of a management model where we're all working underneath it. Then there's informational continuity, and this is where we have all the same information. So informational continuity means that the woman's records follow her, that we know the information from the last provider, that we keep track of what happens with her, and that we're operating within the same management continuity, and that includes the same protocols and policies, that they're not different across the spectrum. And then relationship continuity, and this is where the small group of care providers comes in, the continuity of carer. This is when the woman and the family develop a relationship with their caregiver, and they may be able to develop a relationship with a few caregivers. I always think maybe 3 or 4, but I don't think they can develop a relationship with 20. So this is where we start thinking about our models of care. How do we ensure management continuity, so the same framework? How do we ensure information continuity, the same information following the woman? And then how do we make the best of relationship continuity, that this relational aspect of the care, to ensure that women and families feel connected and are able to connect with their providers in whichever way they work. So just to put this in a model, and you might have seen this in different sort of frameworks, you kind of have to have all 3 at one level. And this is a really important part of collaborative teamwork, is that we try and get a little bit of all aspects working together. So if we look at the evidence, and I'm going to start with the evidence of continuity of care, and this is the Cochrane review from Megan Boren and her team, which was published. It's been updated recently, but this was published in 2017, showed that women who receive continuous labour support may be more likely to give birth spontaneously, which is defined in this paper as giving birth vaginally with neither von Toos forceps or cesarean. And in addition, this review showed that women may be less likely to use pain medications or have a cesarean, and certainly more likely to be satisfied and have shorter labours. So continuous support, that one-to-one support in labour. And the original research many years ago was with doula support, which is, and more research obviously over time has supported that and Deborah will talk a little bit more about that in a moment. But the continuity of care, the sitting with people in labour, not jumping in and out of the room, not being somewhere else, actually sitting and supporting the people is absolutely critical and makes a really big difference. So then we've got the next aspect that I showed you on that previous slide, which is the relationship-based care, and this is continuity of carer. So this is having small groups of midwives caring for women. And in this review, the groups were actually range from 4 midwives in a group to about 8 midwives in a group. So, you know, not one midwife, but a small group. Who cared for women. This is a large systematic review now across a number of countries, at the moment all high-income countries, but we're hoping for some low to middle-income countries in future reviews. This is the work led by Jane Sandel that I'm sure many of you will be very familiar with. And this showed real benefits, less likely to have epidural, fewer episiotomies, fewer instrumental births, and the chances of a spontaneous vaginal birth being increased. So this is a really important review that's fed into all the WHO guidelines now, and which is why we have a midwifery continuity of care recommendation in the WHO guidelines. And 2 nice infographics from this work. One of the really interesting things around midwifery-led continuity of care is this reduction in preterm birth. And this is really important. And we're starting to explore this a lot more, trying to understand what is the mechanism around reducing preterm birth. And it's really hard to reduce preterm birth, but this is something to consider, that it actually has other benefits. Yes, we know women like this model of care. They have higher ratings of satisfaction. They feel better informed. They feel better prepared. They feel more in control. So some really important experiential outcomes, but also now we actually have some really interesting data about preterm birth and perinatal loss. So really critical things in this review. I'm from Australia, and we have real concerns about our Indigenous populations and the gap between preterm birth rate for Indigenous women, Aboriginal and Torres Strait Islander women, and non-Indigenous women. And we've seen across now, sadly, the last 20 years, Indigenous women have a preterm birth rate that's almost twice the rate of non-Indigenous women. So working really hard to think about how do we shift that. And the work from Jane Sandel's review showing preterm birth reductions has led to a couple of really important studies led by my colleague Sue Kildea, and these 2 papers here, which is called A Birthing on Country Service Redesign. And essentially this is midwifery continuity of care for Aboriginal and Torres Strait Islander women. Interestingly, that these women in a urban area in Brisbane, so in a major capital city, and the study showed that women were less likely to have a baby born preterm, and they were more likely to attend more antenatal visits because of this, we think because of this relationship that the women had developed with their caregivers, and they trusted them. It's very exciting to see more work on midwifery-led continuity of care now in low to middle income contexts. And this is a really nice piece of work led by colleagues, Berit Mortensen and her colleagues in Palestine. And this is in a government hospital and 10 rural villages. So a really complex area. And they showed in these two papers, midwife-led continuity led to less unplanned cesareans, less anemia, less preterm births. Again, that preterm birth theme keeps coming out, less admission to a neonatal intensive care unit, and higher satisfaction. So we're starting to see this model of care, this relationship-based model of care, making a difference in other contexts, which is very exciting. And finally, this is a very recent paper from colleagues in Ethiopia showing that midwife-led continuity of care improved maternal and newborn health outcomes in a rural, low-income context. So women who had this model of care were more likely to have a spontaneous birth and less likely to be preterm. So this is very exciting to see a trial like this, quasi-experimental study showing the same outcomes. And so there's something about this model of care, this continuity, this continuous support that is really making a difference. And it's exciting that the ICI Step 11, again, is reiterating the importance of this way of operating. So what is it about continuity of care that makes a difference? And again, colleagues have done a realist review where they've brought together all the data, and this is from colleagues in the UK, Christina Fernandez-Turenzo and Jane Sandal's group, really unpicking this now. And it seems clear that it's about relationships, trust, confidence, and advocacy. And that helps less stress, people feeling more secure and respected, people being able to access the antenatal care when they need it, particularly early, and these pathways, processes, and systems being managed better and using guidelines. So we now know a lot about why continuity matters and what we can do to make it better. And obviously collaboration is part of that continuity piece. So excitingly this year, 2021, the State of the World's Midwifery report included guidelines and recommendations about midwife-led continuity of care. And this was the first time. We've had reports now since 2011, but this was the first State of the World's Midwifery where continuity of care was absolutely front and centre. And this is a piece contributed by the CEO of the International Confederation of Midwives, Sally Pearman. So State of the World's Midwifery has put out a number of recommendations, and I think it's really exciting to see that communication, partnerships, collaboration and continuity of care are absolutely front and centre now for global midwifery investments and the things that we know need to happen to ensure better outcomes for maternal and newborn health. So you'll see here there's a recommendation about communication, there's a recommendation about continuous partnerships, so again that collaboration between midwives and service users, and this issue about respect, and this feeds into collaboration. So everyone knowing their place and respecting one another within the broader scheme, and this recommendation about midwife-led models of care. So for me, it's really exciting after working in this space for 20 years to finally see everything lining up. So we've got ICI and the important work, particularly Step 11. We've got State of the World's Midwifery with this recommendation, and we have midwifery continuity of care recommendations in the WHO guidelines, the antenatal, intrapartum, and the soon-to-come postnatal guidelines. So it's a really exciting time, I think, to move this work forward. So Step 11, the how-to, for you, thinking about how do you actually do this? So having those links is really important. Thinking about your model of care, making sure that the model you design has those links from the community through to primary care, secondary and tertiary care. and that it includes ways to support stabilization, consultation, transfer, and referral. And while most women won't need transfer and care, some women will be sick and some babies will be sick. So we need to have all of this lined up and ready to go. So one part of step 11, as I said earlier, was to make sure that the mother's aware of and can access the community services that are available. We have this moment in time when we as providers work with women, but they go back out into the world, back out into their community. And so the skilled birth attendants that are in their community, the doulas, absolutely critical part of the piece. And then the broader things. So making sure that there are community services in place for food, for housing, for social support, and for mental health. And there's some, in many countries, there's some really novel and unique and important models being established that I hope that your model can link into depending on your community. So I'm now going to hand over to Deborah, who's going to talk a little bit about the doulas and how we can make sure we include doulas in the care team. Over to you, Deborah.
Thank you so much, Caroline. It's wonderful to just see the full view of step 11, and doulas add to that bridge. You spoke so much, and it's what we describe doulas, community doulas, bring together the community, the providers, and the facilities, so they're adding to that continuity and relationship model of care. And especially for Black, Brown, and Indigenous people, a lot of times in our facilities, although they have continuity, they may not have caregivers that look like them or come for them, their beliefs, values, and sometimes even have language differences. So having a doula who can look like them, who may have the same roots and beliefs and values, can really add to the team. And part of the doula's role is facilitating good communication between everyone, bringing that respect all the way around. And so doulas do a lot of work in that informed decision making that again benefits from having that broad view of community, provider, and facility. But this is a picture of me. Actually, this is my daughter's birth. So we're welcoming a grandbaby in. And I'm working at a hospital literally just like 5 minutes from my home, where I've been blessed to be a doula for more than 30 years. And I have to say, it's amazing as facilities have opened up to doulas. And I want to give voice, especially if many of you are from facilities that haven't had a doula before. It wasn't always easy. There was, initially barriers to say, are doulas stepping on anyone's toes? Do we need someone else in a busy facility that's there? And I'm really blessed to say that in our community facilities, they now embrace doulas. We've had opportunities to have good discussions, to come together and dialogue not only the challenges of building relationship, but also looking at all the benefits, as we just heard, the many benefits that science is telling us we get from that continuity and from relationships and working together. So I have a fun story in that during the beginning of the pandemic, doulas were not allowed in facilities. Sometimes family members weren't allowed, and we really minimized who was there to keep birth safe. But when in our region, doulas were considered an essential part of the team, the staff who was overworking and realizing the difference that doulas had been making in the past really saw the gaps. And so they fought for doulas to come back and be an essential part. And I was at a birth, not this birth, but another birth. And the nurses came in and whispered to me and said, Deborah, we have to tell you, we have 4 people in labor tonight and we have 4 doulas here. And us as nurses, if you can stick your head in the hallway for a minute, we want to give you a round of applause, because many of us took some time to get convinced that adding someone to the team was a good thing. But when we missed you for those months where you weren't here, we really could appreciate the difference that adding someone from the community to do that continuity where others may change shift or have to care for more than one person at a time. You always gave us peace of mind to know you were there and really understood our client and could facilitate that we understood their needs and desires as well. So all of us doulas got to poke our head in the hallway for just a second and get all these applause from doctors, nurses, and midwives. And it was a special moment of just recognizing that it does take a team. It's like building the village. And together we lift each other, and ideally we lift our clients to better and more positive birth experiences. So thank you.
What a fabulous story. That's just brilliant, Deborah. Thank you so much. And a lovely photo. Thank you for sharing a photo of your daughter. That's just gorgeous. And there you are again.
Yes, and this is a good one to kind of end with. So I have my arm around midwife Lonnie Morris. She is one of our pioneering midwives in our community, a great teacher. And so we've worked together for 30 years, and it really is relationship building, as you talked about. We've been able to build such a strong relationship with each other in working together and in caring for people in our community. So I love this photo of us celebrating those moments after the babies arrived together. Just a precious moment. And I don't know if we have one more picture. I don't know if it was put in. Let's see. No. So I had a picture of me giving Lonnie a massage. And I have to say, as doulas, a lot of time we're there to care for our clients, but we're also there to facilitate and honor the team. And Lonnie in particular, when labor gets really long at a birth, she'll always turn to me and give me her back, and she'll go, you know, I need a little love too on these shoulders. So I periodically give her some massaging along the way. But that was taking time to build trust, to build relationships, and to have really good communication. So wherever people are in welcoming doulas in, it is a journey. It does take time, but I hope that you will see and feel the rewards of welcoming doulas and expanding that team of collaboration.
Thank you so much, Deborah. I think that's really great message around relationship-based care is not just the relationship between the provider and the woman, the person giving birth. It's also the relationship between the providers. So in your case, between you and the midwives. And I think, you know, between the midwives, the doulas, the obstetricians, the psychiatrists, all the other people. I mean, relationship-based care goes both ways, and will be better if we're all trusting and supporting one another. So thank you so much. It's really lovely insights from you. I'm now going to hand over to Nessie, who's going to give us some of her experiences around this important area of step 11.
So honored actually to share this speech with Caroline and also Debra. Thank you so much. As you mentioned, I am a different role. I'm a birth psychotherapist during the labor and before and after the natal period. So I am here to representing Istanbul Birth Academy, ISPPM, Perinatal Psychology Association, and also Hand to Hand for Birth Association. So let's start what I am, and let's start what I am doing in the labor. So first of all, I would like to hello from my city, and I hope you're gonna come and visit me sometime. Because it's actually related with our step 11, because it's all connection, all religions, all people, all continents to come together in the same place, and it's a very nice collaboration actually. So my question is, starting, what is birth psychotherapy is, and also who is this role? what am I doing? I'm going to say my I, but please think about what is birth psychotherapy is doing in the especially the labor ward. So my question is always like, well, is there something missing during the labor, the psychology, especially psychotherapy? But then, as a psychotherapist, years, maybe 30 years now this year. So I was also questioning if it is working and if there is a need also for mothers, fathers, also medical staff, work team. And then I realized I can combine different psychotherapeutic schools and to do something in the labor if there is a prolonged labor, if there is any stuckness, or if there is any psychological disturbance, either from the mother or father or medical staff or birth team. So let's go if it is possible to do a birth psychotherapy in the labor. But first of all, I need to explain how you can become a birth psychotherapist because it's quite new. Even maybe you haven't heard before, or maybe it is the first time you hear birth psychotherapist. Actually, it's quite new, and I have been giving the training. And also, I have been myself being in the labor with my birthing team together since 2013. So the birth psychotherapist is actually a doula, must be, childbirth educator, and the psychotherapist herself. So first of all, she must already working with the adults as a psychotherapeutic settings. And then after the training, becoming a doula, childbirth educator, and doing lots of internships and lots of modules, it takes like more or less maximum 2 years to become a birth psychotherapist. So as you can imagine, there is no any space or any possibility to talk a lot of, talking, like, with the left brain during the labor for the mothers. So that's why it's very important to use expressive psychotherapists and not lots of working, lots of talking, especially. So that's why birth psychotherapists needs to have a either psychodrama, gestalt, or any kind of expressive techniques in the background. So since I decided to become a birth psychotherapist and to create this training, I decided to work with the team together. So obstetrician, midwife, and the birth psychotherapist, we created a team and we call it Birth with No Regretting. Maybe you can imagine, or maybe you can guess, but in Turkey, especially in this kind of countries, where the C-section rate is so high, I think it's around 55, 56, more or less. So it means we have to work with the collaboration and we have to work with the team. So we decided to be together, and all these titles, the doctor, obstetrician, midwife, and the birth psychologist, are become or be doula already. So you can find it very interesting. Obstetrician, doula, midwife, doula. Well, this is actually our point of view is it's a little bit different, and we find it's the doula umbrella. So it means everybody knows how we can treat each other, and we have a mutual language together. So doula, let's say doula is our cover, and we are sharing all the same thing together. We are in the same boat together. So birth psychotherapist, actually, what is she doing? First of all, birth psychotherapies is for, of course, for the mother, father, parent, let's say, whoever they are, and for the baby. And for the medical team, it would be, in your case, obstetrician, or midwife or doula or any medical people if there is a medical and hospital setting. And if it is a home birth setting, it could be any kind of birth helpers. And also birth psychotherapist is for family members. When I say family members, it means extended family members like grandmothers, grandfathers, or if there is any sisters or sister-in-law or like aunt or anybody who has got maybe some questions or maybe previous birth traumas in her or in his life. These are very important and very crucial role during the labor. So I would like to share some photos. Here I'm actually trying to explore if the mother is holding something or is somehow her heart or her brain is somewhere else. So I'm trying to actually get her to be here and now, which is very important. So as I mentioned before, birth psychotherapies is also for fathers. So you can see I'm holding the father, which he was kind of crying in a very important moment. And then in the first picture, you can see also I am also supporting for the big sister. She was also she came in the water. She was a water birth baby. And now she was welcoming her little sister. So birth psychotherapist is also working in the seabirds in the theater. So taking care of the continuity of support. So if there is the labor goes into the C-section way, let's say, we don't need to stop our support. I'm still there with the midwife together, and the doctor is doing his own job, and the midwife is supporting for the breastfeeding and skin-to-skin contact, and if the baby is ready. And then also I am supporting as a birth psychotherapist. Still, she, her, baby, and the father needs to have a very great experience and without any regret, which is very important. And then you can also see our chapter in Betty Ann Davis and Robbie Davis Floyd's book. It's called Birthing Models on the Human Right Frontiers. So, well, I don't know if you have birth psychotherapists in your country, please contact with them. It is also a kind of a communication together and collaboration together. If not, try to connect with me. So let's see what we can do together and how we can create your own birth psychotherapy trainings in your country. And if it is possible, please don't leave yourself alone. Try to build and create a birthing team together. It could be all different teams and all different roles. Midwives, nurses, obstetricians, doula, midwife doula, psychologists, all these triples, doubles together, because it all depends on your countries and your areas working conditions. And of course, my dream is to take the pre and perinatal psychology classes or workshops or any kind of information into the midwifery and also medical school.
So thank you so much, Nessie. That was just perfect. And I think, again, reiterates the importance of step 11 and the work that we've been talking about. So, of course, in all the ICI work, it's really important to measure what you're doing. And so developing indicators, having indicators, this is some work that has been shown already from previous evaluations that working together does improve good relationships between a facility and the community. And if we all understand the policies, we all understand the practice, we can all work together. It will make for better outcomes, for better interactions between all the providers. And this continuous care just makes such a difference. And whatever research we do in this space, women, people giving birth, always say that it makes a difference. So just finally, some take-home messages. So each woman, each pregnant person and their family encounters a wide range of professional and vocational care providers during their maternity episode. And one of the key areas in this step is to bring that number to being manageable, to being that there is person-centered care, that there is relationship-based care, and that there's collaboration, and that you need to bring that to a manageable level of people who work together well, who work together nicely, who understand each other and trust one another. And so those respectful, trusting relationships between all concerned is really important. And as the evidence grows and develops, particularly now outside of high-income countries, we know that midwifery continuity of care is really key. And we've heard from Debra today about including doulas in that model is really important. So lots of evidence, lots of references, and I know you can get hold of all of these from the ICI website. There's a lot of great resources available. So thank you so much. I'll stop there.
Thank you so much, Caroline and Debra and Nessie. I really appreciate you taking the time to put this together for us today. It's quite a bit of material, but I think maybe I'll just pose a couple of questions to you and we can discuss further some of these ideas that I think are really critical. So I was thinking while listening to you speak, Caroline, we have some facilities who are set in areas where they're really beset by staff shortages or shortages of critical providers, whether that's not having enough midwives or even not having local certification for midwives or not having obstetricians. Have you worked in some settings, or would you have any sort of advice for a group that is looking at this step and thinking, oh, we don't have access to some of these providers, so feeling that it's really challenging to try to tackle this step?
Yeah, look, that's the reality in lots of places, isn't it, Michelle, that either you don't have the providers or they're not the right providers. So I think it's about looking at your context and thinking about what you do have rather than what you don't have. So you might have some midwives or some nurses who are providing maternity care. Perhaps you can develop a doula program so that women do get that continuous support. And I think particularly when there's not enough midwives, and sometimes women are not allowed or able to have companionship in labour because of the structure of the labour ward, and it doesn't enable other companions to come. I think thinking about what you do have. So do you have doulas? Could you develop some form of continuity of care, for example? So if you did have some midwives or nurses, could they go and provide some antenatal care in the clinic? And so they might meet some of the women when they come in labour. And even if they meet some, that's better than none. So I think thinking about what are the things that we can do. And of course, then the broader advocacy piece is about advocating for more midwives, advocating for a health. We know midwives save lives. We know midwives make a difference. So we really, there is no evidence anymore to not do this. I know that's a long piece, and I work in countries where, that's a 20-year plan, but you have to start making it now. Because if you don't start making it now, the 20 years comes really fast, and then we still don't have enough midwives. So I think working with what you have, trying to be creative around what you have, and then having a plan for the future would be my steps.
I love this idea, Caroline. I think that's very helpful, because I think we just want to make sure that we're contextualizing it we're always trying to look at all the angles for these 12 steps. You know, even if at first you look at this problem and think it can't be done in your setting, there are ways to modify it, to look at it from a different angle. So I think that's really fantastic.
And one of the other areas, Michelle, I think that the pandemic has taught us is that digital options for collaboration are now a reality. And even if it's just a phone call or some text messaging, but you know, there are more sophisticated platforms now that many countries, even low middle income countries, are using. And I've seen some really incredible work across my region in countries like Laos and Bangladesh, where that collaboration, that using digital technology to talk to the providers at the next facility, at the next level facility, ensuring that the providers at the primary level or in the community feel less isolated. And so while collaboration may not be an obstetrician standing next to you, it might be an obstetrician or a neonatologist or someone who understands higher level care on the phone. And so we need to think about how we can use those technologies more cleverly now.
Wonderful. And so Deborah, I wanted to direct a question to you because I know some of our sites are looking at bringing doulas in for the first time. So do you have any words of advice for them? You know, or even maybe they're looking at bringing in other new providers. So based on your experience of watching the system change as doulas became more and more accepted and commonly available, do you have any sort of feedback to from the facility perspective of what can they do during those first months and years if they're trying to bring new providers in?
Yes, and thank you, Michelle. I've been blessed to set up doula programs in 40 different countries. And so going in and meeting with hospitals and facilities, and one of my number one tips is do the training there at the facility so the community already comes in, and invite providers if they can't attend the whole time, probably not because their time is limited, but at least come in at periodic times, start building those relationships, start building those trust, helping sure that everybody has clarity on what the doula role is, where it begins, where it ends, and how they support and integrate with good nursing, midwifery, and physician care. So if you can build that into the training and build those relationships from the start. The other thing that I found incredibly helpful, and part of the ICI, right, is to have a committee with multidiscipline talking, is to really get that committee going and getting feedback. Because whenever you start something new, you're going to have obstacles, you're going to have people unsure. And so communication is really important, that everybody has a place to bring any concerns, to be heard, and that these can be addressed early. But other than that, pretty quickly, I find that once doulas that are trained fully understand their role and scope of practice, are integrating with the team, and that piece is important. Doulas really have a defined role, and we have to make sure that everyone understands that scope of practice, where it begins and ends. Usually pretty quickly, there are a lot of positive stories, and we start seeing really good feedback from the people that are giving birth. And that kind of gives everybody more motivation to overcome any obstacles that they might be feeling. But I think everybody needs a voice, and everybody needs to understand what is that doula role and scope of practice.
Wonderful. Thank you so much, Deborah. And I appreciate that you tie this into the ICI context of how we implement, and that we have those multidisciplinary committees that should be representing all the different professions. And so that you're right, that is a point that really is relevant for step 11. I'm afraid we're out of time, but I want to thank you all so much for sharing your knowledge and experience and really giving people a really fantastic sense of what is meant when we're talking about step 11, unpacking all the pieces and how to go about it. So I want to thank you so much. And I also want to say thank you to everyone who's joined us for this webinar. You've made it hopefully almost through all of the 12 steps if you're going in sequence at this point. We hope that you are going on to watch all of the other sessions in this series. and that we'll be seeing you again with us soon.